Okay, here we go. We are going to hit basics of EKGs, number 6, in this unknown part series. So I encourage anybody who hasn't listened to previous videos to watch videos 1 and 2. It describes what I consider to be the basics. I think it goes into enough detail to where if you don't understand something, there's enough context provided by the video and information provided by me to continue your research on your own, or at least know which concepts are confusing or you need more clarification on. I'm a fan of understanding conceptual knowledge, not necessarily memorizing very, very tedious rules, because while it is important to know some basic things that require memorization, such as what your intervals should be, because you don't know that your interval's abnormal unless you know what a normal interval is. But also to understand kind of conceptually what looks right and what looks wrong, so you know when you should analyze an EKG more. Of course, there are many layers to this kind of way of thinking that I'm trying to get across to people, or trying to convey, rather. I think there's a lot of basics, and a lot of it is added on top of each other. And when in this spectrum of making decisions, do you know what to look for and what to not look for? Well, I think that's a multifaceted answer. I think that some of it comes down to memorization. You do have to remember some things. There's rules, medications, mechanisms of actions, indications, contraindications, protocols, and procedures. You do have to memorize where ECG leads are placed. You have to know where AED pads are placed. You have to know relatively which jewel selection. So you have to have an idea of ranges in rules and formulas and numbers and medications and dosages, things like that, to know when to apply a certain thing. My caveat to that statement is that I'm fearful that without the proper knowledge or conceptual understanding of a concept, that was redundant, a conceptual understanding in general, you may incorrectly apply something you've memorized to the wrong situation because you've only memorized, you don't understand the concept. Conversely, you may neglect or fail to apply something in a particular setting because you've only memorized the rule, but you haven't memorized when to apply it. So the name of the game is applying the appropriate intervention in the appropriate setting. And then if you need to look up rules in terms of access and numbers, and it's Tuesday and you carry this to the third power and it's sunny and wind is coming out of the northwest and subsection paragraph 4, if you have to remember stuff like that, then I think you're remembering too much. But if you have to reference it and you understand the concept, it's just a quick, bloop, the number is 9, But if you don't know where to look and you're looking through all your pages, then you kind of waste time. So understand the concept, familiarize yourself with approximate or somewhat appropriate ranges of things, so that way you don't completely underdose or overdose a patient, if we're talking about medication administration here. If you need to administer 10 milligrams and there's a buffer, like nothing less than 6 milligrams will work. It won't be effective, so you won't hit your minimum concentration. 10 is ideal, and anything above 20 is lethal. If you give 8, is somebody going to be like, well, the dose is 10? Yeah, maybe, but does it still work? Yeah, also yes. So I'm not saying do the incorrect thing, but I'm saying, there's a little bit of wiggle room to the left and the right, depending on the contextual information you get and the patient's body size, age, all this stuff. So there's many layers to this. One of the layers is the patient's comorbidity status, their current condition. There are other health things that are going on. Does somebody have an elevated troponin, but they're hypoxic? Is there sort of generic EKG abnormalities that don't really pinpoint to a particular area, but the patient has been in a COPD exacerbation for like a day, and they ran out of, or they took a steroid taper and maybe they tapered off steroids too quickly and they ran out of oxygen or albuterol or something? Yeah, I mean, I think the point is to not get fixated on any one particular area. That sounds kind of confusing or maybe even contradictory because I'm talking about basics of EKG, but understand that there's layers to this. There's reasons why patients might have chest pain. It might not be an MI. There's reasons why patients' blood pressure may not be low. It may not be because the right ventricle is not working. So we are honing in on a very niche area, a very specific area that I am particularly fond of. And I think it's worth understanding all of the basics of EKGs, patient positioning, blood pressures, intervals in terms of the P wave, QRS, and T wave, ST segment, all that stuff, what a normal EKG looks like. And then you add all these basics on top of each other. However, that being said, there's also other parts of the body. There's the respiratory system, there's the nervous system, there's cancer, there's metabolic derangements, there's electrolyte abnormalities, there's temperature variances, there's toxins, drugs, alcohol. There's patients that have weird baselines. There's genetic disorders. So in that sense, each area is also kind of like a basic area. Could you have a respiratory and a cardiac condition added on top of each other? Yeah, it's your job to try to like figure out what you should treat first. So this comes into like more of a philosophical understanding about medicine. And a lot of this comes with time, patient exposure, doing case reviews, and then having like an open mindset so you can take constructive criticism, teach other people things, and then learn from other people. That idea, if you have that idea kind of impregnated into your brain, then the rate, in my opinion, the rate at which you succeed or improve in medicine kind of exponentially increases. Without this mindset, I think you're likely to reach a level of stagnation. So to summarize, what I am trying to do is talk about a bunch of basic principles every single time I want to go through these videos, but understand that this concept is not limited to just cardiology. It can be applied to every part of the body, every part of your decision-making, every part of the totality of the circumstances that led you to be in front of a patient treating their complaint or their problem that they called you for. All that being said, I'd like to summarize the basics in every video. I already did that in this video, I think. If you're missing some of them, watch videos 1 and 2. I want to talk about one cool little thing that I'll dive into details with. And then like always, we'll go through waving cases, including the basics. Ensure we include all the basics every single time so we develop a systematic approach. And then if we happen to find an EKG, because I don't look at these before recording these videos, that talks about what my topic is of the day, great. We can apply it in real time, then you get to see it in the same video. If not, every time we go through something that's encountered that's new, I think my intent would be to briefly talk about why, and then encourage people to do their own research on their, or message me with questions. And if I identify a concept that, in my opinion, is basic, and I need to totally time out and do that concept, I would do it in the same video. If not, I'll save it for another video. And I think eventually, through all these cases, not only will I learn a lot, we'll probably talk about almost everything to be successful and safe in terms of cardiology. So I understand that sometimes I talk fast. I think it's probably possible to put these videos at like 75 or 80% speed. That all being said, let's get into it. Today's concept, oops, did not mean to click that, is going to be Sgarbossa criteria. And I've alluded to this on previous videos. So what we have is a principle of proportionality, which is essentially saying that all complexes in all areas on the EKG tend to look a certain way. If there's a way for this to be abnormal, it's going to be one of a few ways. It's going to be because a lead has actually changed its morphology, so the actual appearance of the T wave looks different. It's going to be because there's a prolongation on the x-axis, which means time. So this would be like your your QRS complex looking like this, right? Or it's going to be a change in the amplitude, which means that there's more conduction happening. This is the case with chamber enlargement, atrial enlargement, ventricular hypertrophy, but it's also called ventricular enlargement. But the term we colloquially use is ventricular hypertrophy. And then deviations in the axis. So if a lead is supposed to look like this, but now it looks like this, that's a deviation in the axis. If a T wave is supposed to be upright, but now it's inverted, that's a deviation in its axis. You know, it's 180 degrees flipped. And then any sort of weirdness, like notching, or multiple waves where there's only supposed to be one. Oh, I drew that really crappy. Let's see. But that's kind of a notch too. And then depression or elevation. Elevation, depression. And then there's just like a couple of weird things sprinkled in here or there that you probably should commit to memory. But once you understand all these basics, it's not hard to remember these onesies, twosies, right? We've got like STEMI equivalents or mimics or OMI. We talk about OMI as in like the whole patient scenario with their troponins and the presentation and how old they are and what their comorbidities are and all this stuff kind of like adds to this clinical picture to say, are we suspicious of the myocardial infarction or are we thinking it's something else? Okay, that all being said, we have this term of proportionality, which is essentially saying that if a lead is supposed to look like this, Sgarbossa in particular refers to things that change the shape and the height of the QRS complex. So if you have left ventricular hypertrophy and your QRS complex is supposed to look like that, and now it looks like that, you may have a little bit of elevation at the baseline. Everything's magnified, right? In the precordial section, V1 through V6, up to 2 millimeters of ST elevation can be a normal variant. ST depression is normally not, it's not normal unless there's some sort of like strain pattern or memory cell or paste rhythm, something like that. But in a normal heart, you should never see ST depression in the precordial section. In the inferior and augmented leads, the limb leads and augmented leads, since there's less electricity in the right part of the heart than there is the left part of the heart. That's the right, that's the left. Only up to 1 millimeter of mercury, 1 millivolt of elevation is considered acceptable. Here's where Sgarbossa comes in. If there is LVH, which means you have this like tall R wave or QRS complex, if there's a bundle branch block and it's wide, if there's a pace rhythm, what else? PVCs. All these things that are called aberrant, which means outside of the normal tract of electricity, the SA to AV to Purkinje fibers and bundle and all this stuff. Outside of that, does this QRS complex look wide or tall? And if that's the case, then you would expect, like, consider it just a magnification. If this is what a normal lead looks like, and there's a 0.5 millimeter of elevation, nobody is typically concerned about a 0.5 millimeter of elevation. Oh, one thing that I did forget to say is we have like the appearance. So like, should the ST segment look like this, sloped up, concave, and now it looks like this, or it's flat or straight or anything like that? The appearance. That's a concept as well. So anyways, getting back to it. If you have 0.5 millimeters of elevation, and this is 10 millimeters of elevation, millimeters tall, millivolts. And then you double this because the ventricle is twice its size. I'm just, being simple for the sake of math. And it's like that. You would expect twice as much ST elevation. So 1 millimeter of elevation is normal in this setting. If you had 2 or 3 millimeters of elevation, that would be excessive, given the proportionality of the complex next to it. In contrast, if you divided this 10 into 2, and now you have 5 millimeters of elevation, or 5 millivolts for your R wave, and this was like 0.6, well, that's half, which means if you doubled it and went back to normal, this 0.6 would turn to 1.2. Well, I mean, you know, the precordial, sorry, in the augmented or limb leads, this is considered a STEMI. That is what they mean with proportionality. If your QRS is baby, you tolerate less elevation, depression. If your QRS is baby, you tolerate less of a large T wave. If your QRS complex is huge, you tolerate more ST elevation. So this is just the concept of proportionality. So if you want to look up Sgarbossa criteria, it's going to say like discoordinate elevation or depression more than 20%, maybe 25, I forget, modified Smith-Sgarbossa criteria of the preceding R wave. It's going to say concordant of the millimeter in any lead, and then I forget the other rule. But see, I understand the concept. That's all right. You get points, and anything more than like really anything more than 2 or 3 points or 1 point is STEMI equivalent. If the chase, especially if the patient presents with ACS symptoms. So you have concordant ST elevation. That means that the R wave goes in the same direction as the elevation or it goes down. And you have depression. Well, in V1 through V3, I suppose. So is the R wave up and you have more than 1 millimeter? Is the R wave down and you have more than 1 millimeter? Is the R wave down? This says greater than 5 millimeters, but that's actually might not be modified. It should be 20%, maybe 25% ST ratio. What does it say? I forget if it's 20 or 25%. I mean, let's say it is 20. If it's 19%, does that mean that the patient can't have a myocardial infarction? Oh yeah, so this says greater than 25%. Okay, so 25%. But if this was like 20 to 25 and the patient had like an abnormal EKG compared to previous EKGs and they're like diaphoretic and had chest pain and nauseous, I would be like, uh-oh, I don't like that. So, right, theory of proportionality. Okay, I think we should get into it then. So let's keep in mind the theory of proportionality. Look up Sgarbossa criteria, but don't limit yourself to only applying Sgarbossa criteria to your findings. Like the theory of proportionality, in my opinion, applies to all leads, all complexes, P, QRS, T, segments, everything. It's a theory of, so I think that Sgarbossa personally, and I've got no evidence to back this up really, but Sgarbossa is kind of like a subset of this proportionality concept, whereas proportionality concept is sort of that overarching umbrella term. So if you see something that looks excessively large, wide, inverted, peaked, tented, notched, anything like that, compared to what it normally looks like, then I consider that to be clinically significant, especially if you can identify if the finding is new, or so like you look up an EKG and voila, they had an EKG 2 days ago and it did not look like this. If they have ACS symptoms or if they have comorbidities or complications that would increase their risk. Old age, hypertension, diabetes, especially if it's uncontrolled, previous MI, coronary artery disease, atherosclerosis, hyperlipidemia, what else? Any sort of previous cardiac surgery, like a CABG, anything that could disturb the coronary blood flow or lead to cardiac remodeling or structural heart disease or ischemic areas, anything like that. Those all increase the risk. And the more poor your patient presents, the older and more comorbid they are, diabetes, kidney failure, obesity, hypertension, et cetera, then the more suspicious I become when I identify that an EKG does not look normal. And the more hyper analytical I become when there are changes. And if there are changes, and I can be like, ah, yes, it was 0.6 millimeters, now it's 0.8, or then it was 0.8, then it was 1, now it's 1.1, STEMI. You know what I mean? So identify trends, and then that would be called the dynamic EKG. So today's concept, in addition to the basics we've discussed in video 1 and video 2, is the term or the concept of proportionality. And then the example that's defined and supported in literature is Sgarbossa. So look that up. All right. Let's get into it. I believe we were like on like number 40 or something around here. Oh yeah, this is the one that stumped me, and then I said the F word. I think we did that. Okay. Sorry, I'm covering up the answers, so it's hard to see. Did we do this one? I don't think we did. I think we opened this one, and then we were like, nah, I don't feel like it. Okay. Normal or abnormal? Abnormal. What's the rate? Kind of slow. Let's figure it out together. Let's do the box method. That would be 300. So I'm going from this QRS complex. Or we can go from this one. 300, 150, 100, 75, 60, 50. So it's between 50 and 60 beats a minute. And then we could do the 10-second rule where we go 1, 2, 3, 4, 5, 6, 7, 8. That looks like a aberrant beat. 9, 10, 60. So if you don't include the aberrant beat, it would be 9 times 6, which is 54. So yeah, something like that. Okay. It looks abnormal. We definitely decided that. The rate is kind of slow. Let's look at all of the complexes. I don't see any P waves, at least not in front of the QRS complex. So this is not sinus. I see an aberrant beat. This is a PVC. Yep. You could apply Sgarbossa to a lone single PVC, technically. This is wide. And let's look at the T waves. There's a little bit of a wandering baseline and some artifact. It's not much. That looks super weird. I don't know how to define that. We'll get into that in a little bit. I don't know if that's an R prime, if this is a weird looking bundle branch block, or if the leads are placed funny. Okay, we'll do that after. There may be some ST depression here. Like if that's part of the QRS complex, does that mean that this here, somewhere around here, is where the ST segment is? Because it does look like there's some ST depression. Remember we said ST depression in the precordial sections never lead normal. There's also an R wave here. But ST depression in the posterior means what? ST elevation, because it's mirror imaged, which means an R wave in the posterior means what? A Q wave, because we're looking at the posterior part through the anterior segment. There's definitely some ST segment depression here. That's a kind of a large T wave. I can't tell if that's a U wave or artifact. Additionally, there's poor R wave progression. Honestly, this kind of looks MI-ish. Or there's low gain here, kind of. There's a flat ST segment here, here, and here. Don't like that. Down sloping, flat. So there's flat ST segments. So there's definitely ischemia going on. I don't know what to make of these notches. I really don't. Clearly that's a PVC. And then the T waves kind of look broad. It looks like it goes from here all the way to over here somewhere. I don't know where it ends, maybe there. Can't tell if that's a U wave or if this is a biphasic. Well, it's not biphasic because it goes in the same direction. Are there left and right repolarization abnormalities? Boy, I don't know. Oh, and the axis. We didn't talk about that. It's kind of normal. There's a little bit of a slurred S wave here, which is suspicious for some sort of conduction delay. And that looks very small, but it may be a Q wave. Super tiny if it is. All right, what do we make of this? A slow, non-sinus, in the 50s-ish rhythm mildly wide, but not excessively wide, abnormal ST segment depression in numerous leads. I don't see any ST elevation. There is a prolonged, straightened ST segment, which probably, especially in the setting of bradycardia, would prolong the QT interval. There's poor R wave progression with an abnormally tall R wave starting earlier than it should in the precordial section. With the ST depression and the inverted T wave, would be suspicious for some sort of circumflex or like posterior type of MI. Aside from that, there is definitely some sort of like conduction delay. I don't know what this weirdness indicates. This could be a retrograde P wave occurring after this. However, I don't see it in any other lead, really. That being said, you may not see it in any other lead. Let's go back to paint. This is the heart. Oops, let me draw it bigger. This is the right atrium, left atrium, right ventricle, left ventricle. If we have V1 and V2 here and here, and then we have the start of atrial activity. Oh, let me draw a different color. We have the start of atrial activity, but then there's a ton of disease. What color do we want to use for this one? Yellow, maybe. Here. You know, because there's like, if this is a transected area and this is right here is the posterior and this is the anterior section right here, this posterior infarct could make its way up to the anterior, like a blood vessel could go through both sides. You know what I mean? So we may only see, because lead AVL and lead 3 would be down here, right? Maybe something like that. I don't know. AVF? Yeah, AVF. AVL. No, AVF. Yeah. See, I don't remember stuff. Oh well, who cares? Why aren't we seeing this P wave activity down here? Well, maybe it stops. Maybe it doesn't even make it through this area. So we're only seeing it in this lead. So maybe that's just signifying that there's some sort of atrial activity trying to get through, because we lose it right about here. It does look like an inverted P wave. So, or a retrograde P wave. That's what I would call it. Looks funny. It looks really funny. Could be a biphasic. Oh, you know what? It could be a retrograde P wave that has like one side is diseased compared to the other side. Ooh, let's draw that in green. Green's a good checkmark color. So this side may conduct normally, but this side may not. It may trickle backwards. So you know, anything that happens after the QRS complex would be inverted. But if one of them is abnormal and goes in the right direction and one doesn't, then it would be biphasic, like that. Okay, so I don't know. Lots of coronary, a lot of cardiac disease would be my guess. Let's take a look. 69-year female with heart murmurs since teenage years. Oh, have we had this one before? So now that I've seen previous ones with this similar kind of thing, we think of rheumatic heart disease. So I can't talk about the single valve most likely replaced, but I would suspect that because there's atrial disturbance and this is a ventricular rhythm, that is probably the tricuspid valve, because the tricuspid valve comes first right here. I mean, I don't know. It could definitely be the mitral valve as well. Could be both. All right. So we'll say single valve was most likely replaced. Oh, which one was replaced? Okay, so one works and one doesn't. All right. So the one that was replaced probably works. I would say, since there's very limited atrial activity, that the one that's knocked out is probably the tricuspid valve. So we'll say that the mitral valve was replaced. I could have this totally opposite, but that kind of makes sense to me. We'll say the rhythm, junctional, rate of about 55. The access is pretty normal, though. I will say it's pretty normal. So it's either very low atrial, or high junctional, especially because we think we see some retrograde P waves here. What questions are raised by the ventricular repolarization waveform? Well, it's not ideal because there's delayed R wave progression. There's a little bit of widening and there's some S wave slurring. So there's definitely some sort of intraventricular conduction delay. That's my guess. And then overall, we'll say rheumatic disease. I don't think I would have directly said rheumatic disease if I wouldn't have already had 2 of these in the past, but now I'm learning. Show answer. Patient had undergone mitral valve replacement. I got it right. Yes, I did. The ECG here is suggestive but not diagnostic of biventricular hypertrophy. Oh yeah, okay. With a borderline left ventricular hypertrophy. I guess we see a pretty deep S wave there. Pattern in the precordial leads, but with a vertical, albeit not frankly right, axis of about 80 degrees. Yeah, the axis isn't egregious. It's almost 50-50 here, which would be a slightly more rightward axis, which would push it up from 0 to 30 degrees, a little bit up towards like 60 degrees. This combination, especially in adults, prominent precordial voltage due to presumptive LVH with an inferior rightward, not leftward axis may occur with rheumatic heart disease and mitral regurgitation or stenosis. Finding of left atrial abnormality or AFib may be present. This could be AFib. Yep. But it looks pretty regular though. Here, the rhythm is junctional. Aha! Evidenced by retrograde P waves, negative in 2. Oh, I didn't even notice that. Where? I don't see them. I do not see it. Very subtle if they're there. Maybe it's this. That little thing right there. Whoa. A relatively long R to P interval with single ventricular premature beat. An R to P interval. Yeah. Well, yeah, well, duh, because instead of occurring here, it's occurring over here. Also note the long repolarization interval with the U wave. Yeah, we did say that. Yep. Raising the question of drug effect toxicity or hypokalemia. Yeah, especially with flattened T waves. That makes sense. They're kind of wide, but they're not very tall in amplitude. An adult woman with congenital long QT is less likely. The patient was on a phenothiazine type agent. The patient was also on low-dose digoxin, which in concert with the LVH may account for the lateral ST depressions in the absence of ischemia. Oh, that's interesting. Okay, yeah, that's a little bit above my pay grade. Neat. All right, time check, 21 minutes. You know, on my second to last video, I felt like this said 30 minutes, but we were really at an hour. So I don't know what that really means if this is not super accurate. Okay, continuing. Man, it's hard to see with the 3 stars. Okay, covering up the answers with my phone. 4 stars and zoom. Honestly, in terms of abnormality, this does look abnormal, but not as egregiously abnormal as previous ones. Let's hash it out. Rate, kind of slow. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 66 beats on the slow side. Keras complex, narrow, P waves, present. They look notched. So there's probably some sort of atrial disease, atrial abnormality, atrial enlargement, whatever you want to call it. PR interval, it looks all right. Keras interval looks okay. It looks pretty much the same across here, and the rate appears regular. Which is why we can do our counting method. Actually, we could do this method, 300, 150, 175, 60. Yep. On the higher end of closer to 75 than 60. All right. Let's do access. Normal access. Huh. R wave transition. It changes early. There's an R wave here. That's weird. So early transition, but it does switch completely by V4, which this is normal. So you'd kind of wonder, is this a repolarization abnormality or a depolarization abnormality, or is this indicating some sort of like cardiac ischemia or necrotic tissue? Let's see. The T waves in relation to the Keras complexes actually look kind of big, most notably in V2. Second most notable lead would be V3. Third most notable lead would be, I don't know, it's a toss up between lead 2 and lead V4. Lead 2 is probably okay. A little large, but not. These stand out to me, these 3 leads right here. There is some coved shape ST elevation, so the ST segments don't look horrible here. A little bit of notching. Scanning, computing. Small gain here, small gain here, so 3 in AVL. So those are different areas of the heart. So questionable patient body size, questionable lead placement. The PR segment looks okay. Doesn't look, maybe that's a little bit of PR depression because it starts here, goes down. It's almost like 0.5 millimeter. So there might be a little bit of PR depression. Looks like that way here too. Or is the P wave just going, yeah, I think I would call that PR depression. So with the slight elevation in J point scooping, because this does not look flat, this does not look, the ST segment does not look flat, does not look convex. It does not look slanted down or slanted up. So we want it to look like this ordinarily. There are some variances, especially when you get into strain patterns, bundle branch blocks, and LVH, things like that. But does not look pathologic. Like these are pathologic right here, these ones. Yeah, because we're done taking notes. So that being said, there are kind of peaked T waves. They're tented, not broad, and they're symmetrical, not asymmetrical. That's something else we didn't talk about. Symmetrical versus asymmetrical. If a T wave is like this, and it looks the same on both sides, and this is your QRS complex, this is peaked. If your T wave instead looks like this, that's your QRS complex. If your T wave looks like this, notice how it's broad, bulky, meaning a lot of space fits under here. It's greater than 50% of the height of the preceding QRS complex. And it's asymmetrical. This one slants up really fast. I should have drawn it a little better. Yeah, that's slow repolarization. What causes slowness through an electrical conduction tract? Injury, right? Runners with an injured sore leg do not run as fast. They limp on one side where the injury is. So I don't think that these are hyperacute T waves. You can see larger T waves, especially when they're symmetrical, in benign or the repolarization. But there's a little bit of PR depression, and there's poor gain here. That makes me more suspicious for pericarditis. There's a little bit of very subtle trace ST depression here in AVF. So if this patient has like some sort of pulmonary type of chest pain that's like better when they sit up or whatever, when they lean forward, when they take a deep breath, it hurts more. I'm going to be suspicious of pericarditis. I don't see, I can't tell if that's just PR depression. Right? So I can't really tell if that's a Q wave or not. I don't really see any Q waves though. Little bit of slurring here, but not enough for me to call this like an accessory pathway. I will say patients with respiratory infections or any sort of like thing that, or sorry, cardiac irritation, any sort of like strep that can cause pericarditis, you'd expect the heart rate to be a little bit faster, but not impossible. The patient could be beta blocked. I'm going to say pericarditis. Yep. Notch P waves. They do have atrial disease. Low gain here. So this is one where I can only point out the diagnostics of it. There's a small P wave here, actually, very small. So small P waves, small reduced gain in these two leads by themselves. So I can just point out what the abnormalities are, but I can't really make any suggestions here. If I were to say one guess and one guess only, actually let's change it to two. This T wave looks big. It's my secondary guess. Large T waves in this area of the heart, which is congruent. It's the same area. It's like the septal anterior area. This doesn't really look MIH to me, but I will not completely rule out. If a patient had chest pain, we would need to do serial troponins and look for dynamic EKG changes on serial 12 leads. And then we would need to do some sort of infectious workup, would be my guess. The other thing we could check, like always, is electrolytes. So let's see, pericarditis, that's gonna be my main guess, but I don't know. Oh dear. Oh dear, 51-year-old woman, cardiac surgical appointment. Well, this is gonna be tough. Can you figure out the procedure? Mind the P waves. Yeah, they're small and they're biphasic here. Oh boy. Mitral valve replacement for mitral regurgitation. Atrial septal defect, secundum closure. I don't know what that is. Aortic valve replacement for aortic stenosis, coarctation of the aorta repair. Well, let's break this down. Something is causing there to be low gain in lead 3 in AVL, which do run forget where AVL is. I think it's here, AVL. 3. So this actually transects the same area of the heart. I'm going to drill those a little off. It might go like more like here. But that's actually kind of where both valves are. So either both valves are diseased or there's a septal problem, because that's right in the middle. It's going to be my guess. Septal issue. What did it say? Septal defect, secundum closure, atrial. Oh, atrial septal defect. Interesting. So up here. Huh. Something's causing reduced amplitude on this axis here. I don't know enough about subtleties to talk about the valves. There's no R prime in V1 or V2. Well, like a little bit actually. Oopsies, I stand corrected. Coarctation of the aorta, I don't know enough about it. We're going to totally guess and we're going to learn this one together. I'm going to say that there's a septal defect. I don't know, because there's only there's gain issues in just one linear plane. None of these areas call for both. Mitral regurgitation or mitral stenosis. I don't freaking know. That's a guess. This is a 100% a guess. Okay. The patient had severe mitral stenosis and was in for mitral valve replacement. The findings here are quite subtle and illustrate limitations of ECG and the diagnostic sensitivity. Yeah, I'll say. The major ECG finding is prominent left atrial abnormality with minimal RV conduction delay in V2. Yeah. You can relook at this P wave under increased magnification, especially in lead 2 and V1. Yeah, it's notched. The negative component of the P wave. Oh, that's the negative component of the P wave was what was causing this to appear like it was PR depression. Low amplitude, but of increased duration. Oh. Most patients with severe mitral stenosis have a combination of right ventricular hypertrophy with left atrial abnormality. So we were right to say that it was on this plane. We have left atrial and right ventricular hypertrophy. So this is big. And we have a left atrial abnormality. So it is on this plane. We knew something was crossing like that. Or atrial fibrillation. Yeah, I suppose. The QRS here is normal. Yep. The subtle ECG findings in concert with major anatomic abnormality make this case notable. Whenever you see marked left atrial abnormality, always think of occult mitral valve disease as well as cardiomyopathy. Yeah, I mean, I'm not good enough at EKGs to determine mitral valve versus aortic valve or pulmonic stenosis. I do know that like the larger the P wave, the greater the degree of enlargement, you know. Yeah, cardiomyopathy, any sort of hypertrophic heart failure, whether it's diastolic or systolic, left-sided or right-sided, or both, anything like that. I know enough to say something structurally wrong with the heart, but to pinpoint the exact diagnostic, I think you need echo. I think you need labs, maybe even a CT scan or a cardiac MRI if it's really complicated. That was tough. Yeah, very subtle. I would have never picked something like this up. I just would have been like, yeah, that looks kind of weird. If a patient told me they had cardiac history, I'd believe them. All right, let me cover up these answers real quick. 3 stars. Oh, why is that one so hard? Huh. I know it's only 3 stars, but it seems interesting. Well, it's fast. Let's do it. It looks kind of regular. And the complex is like, if you look at each lead by itself, the complexes kind of look the same. A little bit of wandering baseline / artifact. So this looks regular. Fast and regular. All right, let's count. I'm going to go back a little bit. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27. I can't do math. 27 times 6. 162. Yeah, this is fast enough to treat. 162. Is it in the A flutter range? Maybe. However, there's inverted activity kind of everywhere there. So there's retrograde P waves. AVR has ST elevation, and there's a little bit of global ST depression. So there's some sort of like demand ischemia, I would bet, for this. So this is ACLS-ish. Yep. Yep. Looks like AVNRT. There's just like, there's inverted P waves. And, ooh, that's one. Well, that is strange. It looks like there's 2 P waves. Is there like biatrial? Oh yeah, it looks like there's 2 P waves. Maybe that's a flutter wave. And then the other one is buried. Why is it inverted? I've never seen flutter waves to be inverted before. It just looks like that's a P wave, doesn't it? P, P, and it's inverted. And then it also looks like that's a P wave. It's larger after. So is there a biatrial disease? And this is a double reentrant circuit? Because axis is totally leftward. What points leftward? What axis is? So if it's leftward, that means that the axis is over here. When the axis is over here, I get to think about like reentrant circuits with like WPW and stuff. Look that up on your own. It's a little bit of ST abnormality, ST depression globally, ST elevation AVR. Yeah, this is like subendocardial ischemia, whatever they call it, demand ischemia. I'm sure this patient will have elevated troponins, at least trace troponins. Orthodromic. I mean, are there 2 different accessory pathways going on? This just doesn't really look flutterish to me. I mean, it very well could be like a 2-to-1 A flutter. But why is everything inverted? Is it a flutter with lead reversal? I feel like that's harder than 3 stars. My gut tells me this is AV NRT, but it looks like there's double atrial activity, so there could be biatrial disease. Let's find out. What is the rhythm? AV NRT with biatrial disease. Could be totally wrong. I mean, it kind of looks like it. It's regular. It might be one of those like orthodromic ones. Whatever. Let's find out. Oh, a flutter. Shit. Yeah, that was our other guess. The atrial flutter wave, but it's inverted. If it wasn't inverted, I would have for sure said a flutter, 2-to-1 conduction. Note that the atrial flutter, there aren't P waves per se, but there's atrial waves. So if you talk about atrial flutter, do not say P waves. Once you say P waves, the informed listener will probably assume it's not atrial fibrillation or atrial flutter. On the other hand, depending on whom you're talking to, this may not be an issue. Also note that the ventricular hypertrophy, oh yeah, those are big. That's tall there too. Oh, and it's deep. Yeah, it's big. Left axis with possible prior inferior wall MI. Why did they say that? Yeah. Note that the typical flutter waves here, negative polarity in lead 2, as is the case here. Typical flutter waves have negative polarity in lead 2. Huh. I wonder why that is. Let's see what Google AI has to say. Why are flutter waves typically inverted in lead 2? Flutter waves are inverted in lead 2, type 1 atrial flutter, because the re-entrant circuit around the cavo-tricuspid isthmus, or the CTI, causes atrial activation to be predominantly from the inferior to the superior across the left atrium and septum, which is opposite direction from a normal activation of lead 2. This counterclockwise electrical flow creates a dipole that moves away from the positive electrode of lead 2, resulting in a negative downward deflection. Well, let's see if there's a video. Huh, typical A flutter? Okay, well, either way, I mean, maybe you could give flutter adenosine to try to slow it down. It might work. I don't know if the patient was hemodynamically unstable. I think we would just cardiovert him. Yeah, it's a good one to use AP placement. There looks like there's some demand ischemia, so I wouldn't be surprised if they were a little bit unstable. Okay. All right. That was a tough one. 4 stars. Oops, fuck. Oh, shoot, I swore again. All right, we have to skip this one. I accidentally showed the click showed answer. 2 stars. 4 stars. There we go. Oh, this looks abnormal. Whoa, this looks really weird. Rate's okay. Touch slow. 300, 150, 100. Yeah, so, no, never mind. It's okay. There's gross ST abnormality. I see that everywhere. KRAS complex is wide. P waves are inverted in lead V1, V2. Not an abnormal variant. They're biphasic everywhere else. So there's atrial abnormality, enlargement, whatever you call it. There's a prolonged PR interval. See that? Greater than 0.2. ST segment deviation. Oh, that's a good word to use. ST segment deviation. Looks okay. ST depression, ST depression, ST depression. In the inferior segment. It looks okay here, but there's definitely ST elevation in AVL. There's ST elevation in AVR. Oh, it's a really long PR interval. ST elevation in lead V1, V2, V3. Huge in V4. To a lesser extent in V5, and then ST depression in V6. What would be causing ST elevation in V1, V2, V3, V4, V5 with this like reperfusion looking T wave? Flat T waves everywhere else. I don't know if that's artifact or if that's more, if that's double atrial activity. I don't know. See like this too. That little notch right there. That's present there too. I don't know if there's, so in the setting of aberrancy, it's kind of tough to say if there's actually a Q wave or not. So there's intraventricular conduction delay. It's definitely some sort of like delayed R wave progression because we're like inverted all the way to V4. Given that the R wave progression is bad, the axis is slightly leftward. So ST elevation, I'm just gonna call this a STEMI. But what causes, I mean, it makes sense that there's a lateral occlusion because of the AVL elevation and the inferior reciprocal changes. However, it also looks reciprocal in V6, which V6 should kind of match up with AVL and it doesn't. So that's atypical. But definitely V1 through V4 have ST elevation maximal in V3 and V4. I mean, the QRS complexes are really big, but this does not look like a strain pattern. You shouldn't see ST elevation and ST depression. Well, actually, this ST depression here may be a strain pattern along with a T-wave inversion. So we may have a strain pattern that's masking the ST elevation here. Because this does look like a right bone branch block. With an AV node dissociation, you know, because there's PR. Not AV node, sorry, there's PR prolongation, so SA node. This is a very bad occlusion. This may even be like left main coronary artery occlusion because of how many areas are affected. I don't really have anything else to say. Let's see. 78-year-old man with paroxysmal nocturnal dyspnea, findings of increased jugular vein pressure. Ooh, interesting. Bibasilar rails. Oh yeah, heart failure from blown out left ventricle. Widely but physiological split S2 and S3 gallop and a moderate pedal edema. Whoa, yeah, his heart's messed up. He had the same appearing ECG for 5 years with a history of hypertension and a large heart attack in the past. What are the major ECG findings? Cardiac enzyme biomarkers are negative. Oh, interesting. What's the echo likely to show? Well, probably wall motion abnormality, hypokinesis. There is this thing called a persistent ST elevation, and you can see it in a left ventricular aneurysm. Back in the day, before PCI, before cath labs, patients just used to get anticoagulated on like heparin, and then they're like, good luck. So you ended up on developing a weakened left ventricle. This was from LAD and left main occlusions. So this would weaken, and then the increased pressure from probably years of untreated hypertension and all this stuff would cause the weakened wall to expand and balloon out, also known as the left ventricular aneurysm. So it would look like this. And this changes the axis of the heart. And as such, it makes the axis go like, you know, more, it magnifies it. So you get like increased QRS amplitude, which we see. You get a delayed R wave progression because like V1 through, sorry, V4, V5, V6 are like here, right? So some of it, so it's delayed. The electricity moves towards it, and then still part of it moves away as it comes back up. So you get like this biphasic delayed precordial transition zone. Left ventricular aneurysm from a previous MI. That would explain the persistent ST elevation. Yes, it would. Also, the appearance of what looks like left ventricular hypertrophy-ish. Also, the appearance of the strain pattern-ish. Also, the gross ST wave abnormalities. And then there's also probably such significant cardiac disease. If you went untreated from that, or only was treated with medication, not a PCI, then the fact that he has bilateral atrial enlargement or abnormality, as well as valvular disease, as well as, man, this whole heart is diseased. So let's summarize this. He has heart failure. He probably has some sort of cardiomyopathy. I'm going to say a left ventricular aneurysm, past like left main or LAD occlusion, only treated medically. R wave progression delayed, normal-ish axis, perhaps slightly leftward. Well, if there's a left ventricular aneurysm, That would explain leftward access, wouldn't it? And then gross ST, T wave, abnormality. There is strain / cardiac remodeling or scar tissue, whatever you want to call it, evidence. Yeah, I would say previous massive. Oh yeah, there's Q waves. Q wave. It's just an AVL and V5. Left main disease. Maybe even bypass. He probably needed bypass. And a persistent ST elevation. Left ventricular aneurysm from like an LAD or left main occlusion is going to be my guess. Sinus rhythm, prolonged PR interval, we saw that, first degree AV block. Left atrial abnormality, left ventricular hypertrophy, we saw both of those. Oh, I forgot to, did I say the right bundle branch block? I don't remember. I may not have. Most important, the pathological Q waves. Oh yeah, huge. AVL with persistent ST elevation in these leads. Classic ventricular aneurysm pattern. Yep. Q waves with the ST elevation confirmed by echo here. Note that there are many different sets of proposed LVH criteria by ECG features. In this case, the diagnosis is made by using a version of the Rommel Estes criteria, including R wave of 30 millimeters or more V6. Oh yeah, for sure. Let's see. 5, 10, 15, 20, 25, 31-ish, 32. Or more in V5 or I think, yeah, V6, and marked left atrial abnormality. Note that the right bundle branch block decreases the sensitivity of criteria. Oh yeah. Yeah, so you rely on an S wave for ventricular aneurysm, right? So you see a pathological Q wave with an S wave. So it just looks like this normally. And then you can have persistent ST elevation. And then your question will become, so look up normal criteria for left ventricular aneurysm. You're left with Q waves, a deep S wave, especially if you went through V6, and residual ST elevation. However, a right bundle branch block has an R wave here. So a right bundle branch block masks the S wave. So when you mask the S wave, you no longer meet standard left ventricular aneurysm criteria. When you don't meet standard left ventricular aneurysm criteria, if this patient presented with chest pain, you would likely activate the cath lab for it. This is a very subtle and very difficult pre-hospital thing to analyze, especially without an echo. So I don't know of any really good ways to rule in or out a left ventricular aneurysm in the setting of a right bundle branch block. I have read some articles about it, but you can just Google. Let's see if there's one. Oops. Left ventricular aneurysm in the setting of a right bundle branch block. This is complicated because you have two things, right? You have no S wave, there's an R wave, and you have ST elevation. So you're likely to call it a STEMI. With persistent right bundle branch block morphology. Lots of messy EKG. That doesn't look horrible. Oh yeah, look, that's the aneurysm. That's huge. Whoa. Where are my favorites? Like Life in the Fast Lane. Ah. Life in the Fast Lane. Okay. See, really deep S wave. Deep S wave. Deep S wave. Now it just looks like there's Q waves with a big tall R wave. These are the features. Cordial leads, concave or convex morphology associated with well-formed Q or QS complexes. Yep. Two waves have relatively small amplitude. Oh yeah. So you would not see hyperacute T waves. That is also a distinguishing feature. That is a good way to determine the difference. If these T waves are huge, then this would be more indicative of an acute event. But right bonnet branch block. Why can't we find one in both? Left ventricular aneurysm with masked by right bonnet branch block. Masquerading? Is this the one? No. Ventricular aneurysm and cardiac failure. Left bonnet branch morphology. Oh, and right bonnet branch of the precordial leads. Well, I can't find an article with both. Well, that's tough. Anyways, the concept's the same, right? So you don't have a terminal S wave or QS complex because a right bonnet branch block has an R wave. So this is something that hides one of the criteria for left ventricular aneurysm, but it presents with ST elevation. Cool. That is a cool one. Yep. All right. I think we have time for one more. 30 minutes. Yeah. Sweet. All right. Let me cover this up real quick. Good chow. 3 stars. 2, 3. No looking. No peeking. 3 stars. 3 stars. 4 stars. Zoomable. Well, it appears abnormal. The rate's okay. QRS complex is a little bit wide. In V1 and V2, there's S waves, which are atypical. Sorry, not atypical, but there's an R wave preceding it, which is atypical. So is this a left bonnet branch block-esque morphology? Yeah, maybe. Some sort of intraventricular delay. I can't determine where the J point is in leads 1 and AVL. Looks like it's not egregiously elevated. The axis is leftward. And the precordial transition is early. But it still doesn't fully switch. It starts early, but it still doesn't fully switch by lead V4. So, there's definitely atrial activity in the PR interval. Looks good. Maybe even a little short, actually. See? Small gain in this whole area, the left side of the EKG. Small gain everywhere. But normal-esque appearance in V1 through V6. But V6 has small gain too. I wonder if this patient has an infusion or something that's dulling the cardiac electricity. T waves, they're dull in V1, V5, and V6, flat everywhere else. The only normal T waves look like they're in V2, V3, V4. No egregious ST elevation or depression. There's trace ST depression actually in V1, maybe V4. Oh, there's ST elevation in V6 actually. Well, since there's ST elevation in V6, I'm now kind of questioning these leads because this is a congruent part of the heart. This is the lateral. This is like circumflex territory. Something is dulling the QRS amplitude. Let's figure out what it is. History of heart disease. What is the cause of the tall R wave in V1 through V2 here? Well, tough question. What is the cause of the tall R wave? Well, those are either posterior Q waves. So it could be a posterior MI. Especially previous. Could be a left incomplete, left bundle branch block, intraventricular conduction delay. See, I love that term. It's a catch-all. You just know that something's not working through the normal conduction system, especially through the septum. Okay. What else could cause that? That's really all I can think of. Oh, but there's left axis deviation. So left axis deviation with a left bundle branch block-ish morphology. Clearly left heart disease. Huh. I'm going to say that there's some sort of heart failure, cardiac disease. There might be an effusion present. All right, I don't know. We're going to learn together. Ka-chow. Sinus rhythm about 75. Borderline left axis deviation. I thought it was left, not just borderline. Non-specific intraventricular conduction delay. QRS saturation is its widest with fractionation of the waveform in some leads. It looks like V1 and very fractioned in AVL and 1 as well, and V6. The P waves are consistent with left atrial abnormality. Honestly, they're so small I didn't even notice that. I have to zoom in. Most striking are the prominent R waves in V1 and V2 with upright T waves. Yeah. They shouldn't go in the same direction. Not with the Barency. Or yeah. Or conduction delay, I mean. These R waves are most consistent prior MI. We saw that, particularly in context of low amplitude but borderline Q waves and lateral leads. Oh yeah, didn't notice that. There may also be an underlying posterior MI as well. Yep, we saw that. Overall, the ECG speaks to advanced coronary disease with prior lateral or posterior lateral MI. Because there is a little bit of ST elevation here. N2 inversion. The major differential diagnosis in tall R waves include posterior lateral MI, normal or positional variants. Okay, especially in children. Yeah, that's true for sure. Who should have a relatively narrow QRS complex. In adults, it is rare for the R wave to be greater than S, but here it is in V1 with properly placed leads. And in those cases, they may be placed too low in some patients, especially like a female with large breasts, maybe too low. Right ventricular hypertrophy. Yeah, but that usually ends with like a terminal R wave. A vertical, frankly, rightward QRS access is almost always seen, but there's no rightward access here. That's what makes that that's not what this is, because there's leftward access. The T waves are usually inverted in the setting of advanced axis deviation and bundle branch block. Hypertrophic cardiomyopathy, yeah, with or without obstruction, yeah, whatever that means. May simulate a posterior lateral MI, Duchenne muscular dystrophy. I keep reading that. Man, I don't know what it means in this context. Why is this so? Don't know. Right ventricular conduction delay. However, the IVCD, not a right ventricular delay per se, here does not account for the lateral Q waves. That's right, it does not. You should not have Q waves anywhere. Wolff-Parkinson White patterns with posterior or lateral bypass tracks. I'm gonna look that up. It's gonna be my homework for the night. And that's what I do. That is what I do. Put the basics, learn something new, and apply a consistent principle as we go through some sort of systematic approach. All right, see you.